Welcome. In this and the next session, we will be focusing our discussion on spontaneous eye movements. And in this session, we will be restricting our discussion to the major forms of nystagmus: childhood, gaze-evoked and vestibular nystagmus. In the next session, we will be discussing the other important forms of nystagmus and also the nystagmoid spontaneous eye movements. So nystagmus is a spontaneous, involuntary, rhythmic to and fro oscillation of the eyes, which must have at least one slow phase. They are usually categorized either as a jerk nystagmus or a pendular nystagmus. In a jerk nystagmus, there is a slow phase and a fast phase. The slow phase moving the eyes away from the fixation, and the fast corrective phase bringing the eyes back to fixation. The slow phase is the pathologic phase, but the direction of the nystagmus is described by its fast phase. In pendular nystagmus, both phases are slow. In contrast, saccadic intrusions have high speed in both phases, and thus they are not nystagmus by definition and fall in nystagmoid eye movements. In this and the next session, I will be showing the slow phase with a single red arrow and the corrective fast phase with a double green arrow. And in cases of pendular nystagmus, the return movement will be shown as a single green arrow. This video shows a patient with nystagmus, and we can see the involuntary rhythmic to and fro oscillation of the eye. The nystagmus movement in this case is a combined horizontal torsional one. Nystagmus usually arises from dysfunction of supranuclear movement control systems such as the vestibular ocular system and the saccadic system that normally generate a slow movement towards an intended direction. The blue line in this diagram represents the normal direction and the amplitude of the reflex generated by one of these supranuclear systems. And in nystagmus, the slow phase is generated by the pathologic drifting of the eyes away from the intended direction. So if the normal reflex is dysfunctional, the eye appears to drag in the opposite direction. And this drifting away from the intended direction, that is the slow phase, is followed by a corrective movement. This corrective movement can be a fast saccade or a slow movement. So in the corrective phase, this lag or drag of eye movement is corrected in the direction of the reflex movement. In jerk nystagmus, the speed of the slow phase may be constant, accelerating or decelerating. This diagram shows the three types of slow phases that can happen in a jerk nystagmus, and these phases in each represent the slow phases, which drags the eye away from the intended position, and these phases in each represent the fast phase, which return the eye towards the intended position. In this, the velocity is constant, in this one the velocity is accelerating, and in this the velocity of the slow phase is decelerating. Constant velocity of the slow phase is found in vestibular nystagmus. Accelerating velocity of the slow phase is found in infantile nystagmus syndrome or INS. And decelerating slow phase is found in fusion maldevelopmental nystagmus and gaze-evoked nystagmus. And we will be discussing all these four patterns of nystagmus in this session. When we encounter a patient with nystagmus, we have to first establish whether there is any decline in visual acuity, which can happen both with congenital and acquired nystagmus. Whether the patient is experiencing oscillopsia, that is a perception of to and fro movement of the visual space, and we must remember that oscillopsia occurs only with acquired nystagmus, and a patient with congenital nystagmus does not experience oscillopsia. We have to inquire about other associated symptoms such as vertigo, ataxia, motor and sensory weaknesses, and if there is a family history of similar nystagmus. In examination, we have to check for spontaneous eye movement both in the primary gaze and eccentric gazes. Examples of nystagmus only in eccentric gazes include gaze-evoked nystagmus and physiological nystagmus. Devices which help us to determine the type of nystagmus include 20 diopter lens, which blocks fixation as well as provides a high magnification view of the patient's eye, and we can also use Fresnel goggles to block fixation. And recording of the nystagmus waveform can be done with multiple techniques. The nystagmus which we find in a patient should first be described as whether monoocular or binocular, whether jerk or pendular or a saccadic intrusion. To determine that, we have to ask the patient to fixate on a distant stationary target, and then we have to determine the speed of movement away from the target and towards the target. And if the speed of the motion away from the target is slow, then it is a nystagmus, and if the speed away from the target is fast, then it is a saccadic intrusion. And if the movement away from the target is nystagmus, then we determine the speed of movement towards the target, and if it is fast, then it is a jerk nystagmus, and if it is slow, then it is a pendular nystagmus. We have to also determine whether the nystagmus is horizontal, vertical, torsional, or a combined pattern, whether it is continuous, intermittent, or induced. In gaze-evoked nystagmus, we get nystagmus induced in a particular gaze. Whether there is a null point. Null point is the direction of gaze at which the oscillations are minimal, and if the oscillations are minimal, the visual acuity usually improves and the patient may take up a head tilt or a head turn to have the null point straight ahead. Whether the nystagmus movements is symmetrical in either eye or not, so we can have a conjugate nystagmus in which the direction, frequency and amplitudes are the same in either eye. We may have a disconjugate nystagmus in which the amplitudes are different in either eye, or we may have a disjunctive nystagmus in which the directions are different in either eye. And disjunctive nystagmus are often found to be pendular in primary position and jerk in extremes of gaze. We also need to determine the effect of gaze changes, fixation loss and convergence on the nystagmus to label the nystagmus as of a particular type. Alexander's law states that in a jerk nystagmus, the amplitude is increased when the patient takes up gaze in the direction of the fast phase. So in this diagram, which we have discussed in a previous session, we have a patient with a peripheral vestibular jerk nystagmus in which fast phase occurs in a direction opposite to the side of the lesion of the vestibular apparatus, and when the patient takes up a gaze in the direction of the fast phase of the nystagmus, the amplitude of the nystagmus increases. So patients may take up a head turn towards the direction of the fast phase to reduce the nystagmus amplitude and thus improve vision. There is an entity called physiologic endpoint nystagmus, and as the name suggests, it is normal and it occurs in the elderly, and it occurs at both extremes of horizontal gaze. It is of low amplitude, low frequency and occurs for less than 6 seconds, and the amplitude is larger in the abducting eye. And since it is normal, there is absence of other signs and symptoms. Starting with childhood onset nystagmus, and the common patterns of childhood nystagmus include infantile nystagmus syndrome or congenital nystagmus, fusion maldevelopmental nystagmus or latent nystagmus, and spasmus nutans, and we will be discussing each of these. Infantile nystagmus syndrome, abbreviated as INS and more commonly known as congenital nystagmus, is the most common form of nystagmus and constitutes 80% of all nystagmus, and it is usually detected in the first few months of life. And if there is an associated congenital visual loss, it appears by 3 months of age. INS is a conjugate horizontal nystagmus which may be jerk or pendular. If the vision in at least one eye is 6/24 or better, we get a jerk nystagmus, and it is right beating in right gaze and left beating in left gaze. If the vision in the better eye is between 660 and 624, INS is pendular, and if the vision in the better eye is less than 660, we get searching movements of the eyes without any fixation. And as we have seen when discussing the waveforms of nystagmus, the slow phase in INS has an accelerating velocity, which is a unique feature of INS. There is decreased vision, and being of childhood onset, there is no oscillopsia, and it may be associated with a strabismus. In 60% of cases, INS is associated with bilateral pregeniculate lesion occurring before 2 years of age, and it can vary from cataracts, foveal hypoplasia, retinal dystrophy and optic neuropathy. So a large number of ocular pathologies can be associated with INS. In the remaining 40%, however, no pathology in the afferent pathway is detected, and in this situation we may find genetic defects, and the most common being X-linked mutation in the gene FMRD7. INS has no associated CNS dysfunctions. INS may be continuous or intermittent, and if INS is intermittent, the patient has periods of improved visual acuity which are called extended foveation periods. The nystagmus intensity increases with visual attention and/or fixation, and it also increases with illness, but it is abolished during sleep. Intensity of the nystagmus decreases with convergence, and so the visual acuity at near is better than at distance. And because of this, in an isotropic patient with INS, when we try to estimate the amount of isotropic deviation with a base-out prism, the patient increases the convergence and is said to eat up the prism, and this is called nystagmus blockage syndrome. Congenital nystagmus may have a null point, and as we have seen, at a null point the nystagmus is minimal and thus the visual acuity improves, and the patient may take up a head turn or head tilt to have the null point straight ahead. And if the congenital nystagmus is a jerk nystagmus and has a null point, we will find a right jerk nystagmus to the right of the null point and a left jerk nystagmus to the left of the null point. Another characteristic feature of congenital nystagmus is reversal of O'Kane response. In a normal individual with the O'Kane drum rotating in one direction, nystagmus will appear in the opposite direction. However, in a patient with INS with the drum rotating in one direction, the jerk nystagmus in the opposite direction actually decreases, and jerk nystagmus in the direction of drum rotation may appear. In contrast, other jerk nystagmus conditions behave like normal individuals in that with O'Kane drum rotation in one direction, there is intensification of nystagmus in the opposite direction. So the main features of congenital nystagmus or INS, the most common form of nystagmus, can be briefly summarized as 1. It is a horizontal jerk or pendular nystagmus. 2. The nystagmus intensity increases upon attention or taking of visual fixation. 3. The nystagmus intensity decreases with convergence. 4. INS shows a reversal of O'Kane response with the nystagmus intensity increasing in the direction of the O'Kane drum rotation. And 5. The slow phase of INS has an accelerating waveform. Coming to the next pattern of childhood onset nystagmus, the fusional maldevelopmental nystagmus syndrome, commonly known as latent nystagmus. FMNS occurs or is accentuated when one eye is occluded, and it decreases with fusion, and it is said to occur due to disruption of fusion before 6 months of age and is almost always associated with an infantile strabismus, most commonly infantile esotropia, but FMNS may also be seen with infantile exotropia and anisometropia. Vision may be normal in either eye. FMNS is a conjugate horizontal jerk nystagmus, and when one eye is occluded, both eyes have a jerk nystagmus with the first phase towards the unoccluded fixating eye. So in FMNS, when we occlude the left eye, there will be horizontal jerk nystagmus in both the eyes with the direction of the first component towards the unoccluded right eye, and when we occlude the right eye, there will be horizontal jerk nystagmus of both the eyes with the first component directed towards the unoccluded left eye. And nystagmus waveform of FMNS has a constant or decelerating velocity of the slow phase. FMNS may interfere with visual acuity examination because when we examine the visual acuity of an eye by occluding the other eye, nystagmus may occur or may increase in intensity of the unoccluded eye being examined. However, if instead of occlusion we use a plus power lens in front of the eye not being examined, nystagmus may not occur in the eye being examined. FMNS shows smooth pursuit asymmetry, in which the fixating eye shows difficulty of pursuit on the ipsilateral side but not on the contralateral side, and the direction is explained by the direction of the slow phase and the fast phase. FMNS and INS may coexist. FMNS may be associated with other signs of fusion disruption such as dissociated vertical deviation, superior oblique overaction, and inferior oblique overaction. All of these signs of fusion disruption, including FMNS, become more prominent with age. Manifest latent nystagmus is a type of FMNS occurring with decreased vision in one eye, as if that eye is occluded, and the normal eye has a jerk nystagmus with the fast phase in the direction of the normal eye. Electrooculography has shown that true latent nystagmus, in which the nystagmus is present only upon occlusion of one eye, is rare. Hiemann-Bielschowsky phenomena is a monoocular nystagmus, so it is one of those rare forms of nystagmus which is monoocular, and it occurs in an eye with a long-standing poor vision, and the nystagmus may not remit even if the underlying condition is corrected. It is a vertical nystagmus with a pendular or jerk pattern, intermittent, low amplitude and of very low frequency. Etiologies such as gliomas, which may interfere with vision in one eye, must be excluded, and Hiemann-Bielschowsky phenomena may have onset in adulthood also. Spasmus nutans is a childhood nystagmus which disappears within the first decade. The nystagmus in spasmus nutans is disconjugate, may even be monocular, multiplanar, intermittent and variable eye movements, which are typically described as being shimmering with a high frequency and a small amplitude, and typically the movement increases in the abducted eye in the lateral gaze. Spasmus nutans is usually associated with head nodding and torticollis, and head nodding and torticollis in spasmus nutans is said to diminish the intensity of the nystagmus. It may be associated with gliomas and thus needs neuroimaging with retinal dystrophies such as congenital stationary night blindness and other neurodegenerative disorders. So we next come to gaze-evoked nystagmus, and gaze-evoked nystagmus does not happen in primary position but occurs at least at 30-degree gaze position on either side. In contrast to physiological endpoint nystagmus, which occurs further out at gaze position at 45 to 50 degrees. And gaze-evoked nystagmus, in contrast to physiological endpoint nystagmus, have a large amplitude and are sustained. In a gaze-evoked nystagmus, the fast phase occurs towards the direction of the gaze. So when the patient is looking to the left side, the fast phase is towards the left side, and when the patient is looking towards the right side, the fast phase is towards the right side. It follows Alexander's law, that is, amplitude increases with gaze in the direction of the fast phase. So the further out the patient looks, the larger the amplitude of the nystagmus becomes. Gaze-evoked nystagmus is said to occur due to disruption in the neural integrators, which we have discussed when covering the saccadic system in the session on supranuclear control of eye movements. And because of that, there is interruption in the step phase or the tonic innervation in the pulse step mechanism, and following that, orbital elasticity drags the eyes away from the extreme gaze position towards primary position with a corrective saccade in the direction of the gaze. So when the patient attempts to look towards the left side, the inadequacy of the step innervation leads to dragging of the eyes back towards the primary position, followed by a corrective saccade in the direction of the gaze. Gaze-evoked nystagmus can be symmetrical or asymmetrical. It is symmetrical in the right and left gaze with intoxication and diffuse cerebral brainstem and cerebellar disease, and it is asymmetric between the two gazes with unilateral lesions in the brainstem and cerebellum, such as the lateral medullary syndrome or the Wallenberg syndrome, and in this situation the nystagmus intensity is greater in ipsilegional gaze. Infranuclear and myogenic lesions such as myasthenia gravis may also cause a nystagmus which resembles gaze-evoked nystagmus. In myasthenia gravis, after the patient takes up a lateral gaze on one side and fatigue sets in, then only the nystagmus starts, and it has a larger amplitude in the abducting eye. Rebound nystagmus occurs in some patients with gaze-evoked nystagmus, and in these patients with prolonged lateral gaze, the amplitude of the gaze-evoked nystagmus in the direction of the gaze starts to decrease, and on resumption of the primary gaze after the lateral gaze, the direction of the fast phase changes to the opposite side. So a right beating gaze-evoked nystagmus with a right lateral gaze decreases in intensity with prolonged right lateral gaze, and following this prolonged right lateral gaze, when the patient takes up primary position of the eyes again, the direction of the nystagmus changes to the other side. And rebound nystagmus is said to happen due to delayed gain of the tonic innervation, and it occurs with cerebellar disease. Coming to vestibular nystagmus, we have discussed vestibular nystagmus when we covered vestibular ocular system in the session on supranuclear control of eye movements. But we will again go through this topic once more. So vestibular nystagmus is the most common form of acquired nystagmus, and we may have a peripheral vestibular nystagmus or a central vestibular nystagmus. Peripheral vestibular nystagmus is characterized by a horizontal torsional movement, and central nystagmus is characterized by an isolated vertical or an isolated torsional nystagmus. And periodic alternating nystagmus is also a type of central vestibular nystagmus. Peripheral vestibular nystagmus is caused by an unilateral or asymmetric lesion in the peripheral vestibular pathway, which is composed of the labyrinth and the vestibular nerve arising from the labyrinth of the inner ear. And typically in a peripheral vestibular nystagmus, we have a contralesional combined horizontal torsional jerk nystagmus, and this is very important to remember. And the origin of the horizontal torsional movement in a peripheral vestibular nystagmus is because of the following reason. Horizontal semicircular canal of each inner ear is stimulated by ipsilateral horizontal head turn, and upon stimulation it induces a contralateral gaze. So the right horizontal canal upon stimulation induces a contralateral gaze to the left side, and the left horizontal canal upon stimulation induces a contralateral gaze towards the right side. And lesions of the horizontal semicircular canals thus produce a contralesional horizontal jerk nystagmus. Both the anterior and the posterior semicircular canals of each inner ear are stimulated by an ipsilateral head tilt and induces a contralateral torsion of both the eyes. So the anterior and the posterior canals of the right inner ear upon stimulation induces torsion of both the eyes towards the left side, and the anterior and posterior canals of the left inner ear induces torsion of both the eyes towards the right side. So lesions of the anterior and posterior semicircular canals produce contralateral torsional jerk nystagmus. And because of these two causes, peripheral vestibular nystagmus is combined horizontal torsional in nature. We must remember that vertical nystagmus does not occur with peripheral vestibular nystagmus arising from a unilateral lesion in the peripheral vestibular pathway. This is because the anterior semicircular canals, which normally causes upgaze on stimulation by downward head turn, and posterior semicircular canals, which normally causes downgaze on stimulation by upward head turn, neutralize each other when there is a lesion in each inner ear affecting both the anterior and the posterior semicircular canals. An examination of the nystagmus waveform shows a constant velocity in the slow component of the waveform of peripheral vestibular nystagmus. So when the peripheral vestibular apparatus of the right side is affected, we get a jerk nystagmus which is combined horizontal and torsional in the contralesional direction. In contrast to congenital nystagmus, visual attention and fixation decreases the intensity of a peripheral vestibular nystagmus. As a result, if we do ophthalmoscopy of one eye with the other eye occluded, we will find an increase in the nystagmus of the eye being examined. Like other jerk nystagmus, peripheral vestibular nystagmus follows Alexander's rule. Since peripheral vestibular nystagmus arises from an unilateral or asymmetrical lesions of the peripheral vestibular apparatus, in symmetric toxic vestibular neuropathy, we do not find nystagmus. Other symptoms and signs which may occur along with peripheral vestibular nystagmus include sudden onset of vertigo, nausea, vomiting and oscillopsia with perception of self-rotation in the direction of fast component, hearing loss and tinnitus, skew deviation and ocular tilt reaction if the otoliths are also involved, which we have discussed in the session on supranuclear control of eye movements. Symptoms may be worse with certain head movements and positions, and with induced head movements we will be able to demonstrate decreased VOR gain, which we have discussed in the session on supranuclear control of eye movements. Meniere's disease is an irritative disorder with hyperfunctioning of a peripheral vestibular apparatus and thus produces a jerk nystagmus with the fast phase towards the side affected. This is in contrast to the direction of the jerk nystagmus produced by a destructive lesion, in which case the fast phase is directed towards the opposite side. Brandt's nystagmus occurs from a growing cerebellopontine angle tumor. Initially the 8th cranial nerve is involved and we will get a peripheral vestibular nystagmus, and later as the brainstem is compressed we will get a gaze-evoked nystagmus. So in the fully developed form there is a contralesional vestibular jerk nystagmus which is of small amplitude and high frequency, and there is an ipsilesional gaze-evoked nystagmus which is of large amplitude and low frequency. BPPV or benign positional paroxysmal vertigo with nystagmus occurs due to dislodgement of otoconia from the utricle to the semicircular canal. The patient has short-lasting episodes of vertigo induced by changes in head position. BPPV can be detected with the Dix-Hallpike maneuver, and if the test result is positive with this maneuver, we will be able to exclude potentially more serious differentials of acute vertigo. This maneuver assesses the posterior canals primarily. The patient is positioned supine and the head is extended below the body. This is called the head hanging position. And in this head hanging position, the head is alternately rotated in either directions in the horizontal plane. Characteristically, when the head is rotated towards the side of the involved ear, an upbeating nystagmus in the upper eye and a torsional nystagmus in the lower eye occur, and this nystagmus has a latency of few seconds before it starts. Also, the nystagmus is short lasting, and the test is fatigable in the sense that if we repeat the test soon after performing it once, we may not be able to get this sign. Now the classic Dix-Hallpike maneuver tests the posterior canals. The horizontal canals can be tested by rolling the head to the side while in the supine position, in which case we will get a horizontal nystagmus when the head is rotated towards the side of the peripheral vestibular lesion. We now come to central vestibular nystagmus, and this occurs with impaired functioning of the brainstem or the cerebellar or both, which receive input from the anterior and the posterior semicircular canals. In the central connections from vestibular nuclei onwards, the anterior and the posterior canal pathways segregate. Central vestibular nystagmus typically causes either an isolated vertical or an isolated torsional nystagmus, and this is in contrast to the peripheral vestibular nystagmus which we have just discussed, which is characteristically a combined horizontal torsional nystagmus. Anterior semicircular canals of the right and the left inner ears is stimulated by downward head rotation, and upon stimulation produces upgaze. Similarly, the posterior semicircular canals of the right and left inner ears are stimulated by upward head rotation, and on stimulation they produce downward gaze. And after the anterior and the posterior canal pathways segregate, lesions of the central pathway of the anterior semicircular canals result in upbeat nystagmus, and lesions of the central pathway of the posterior semicircular canal results in downbeat nystagmus. Fixation does not dampen the nystagmus intensity in case of central vestibular nystagmus. This is in contrast to peripheral vestibular nystagmus, in which case fixation dampens the nystagmus intensity, and is also in contrast to congenital nystagmus, in which case fixation increases the nystagmus intensity. So the effect of fixation on nystagmus intensity can also aid us in differentiating between central vestibular nystagmus, peripheral vestibular nystagmus, and congenital nystagmus. If there is no other symptoms and signs along with a central vestibular nystagmus, we won't be able to localize the lesion. hinge testing, that is head impulse test, nystagmus testing, and presence of skew deviation can help us to differentiate a peripheral lesion from a central CNS lesion in case of a patient having vestibular symptoms. Downbeat nystagmus is the most common form of central vestibular nystagmus, and we find the downward beating in the primary position, and it characteristically increases with lateral gaze and convergence. So this is in contrast to congenital nystagmus. The velocity of the slow phase in case of a downbeating nystagmus can be accelerating, decelerating, or constant. Downbeat nystagmus is said to occur with lesions of the vestibular cerebellum as well as lesions of the cervicomedullary junction. This is important to remember. So if there is a lesion of the pathway which normally inhibits the dominant anterior semicircular input, there will be relative overaction of the anterior semicircular input and a relative underaction of the posterior semicircular input, resulting in a downbeat nystagmus. And like other jerk nystagmus, downbeat nystagmus follows Alexander's rule, and the patient may have debilitating oscillopsia. In upbeat nystagmus, we will find an upward beating nystagmus in primary position, and like downbeat nystagmus, velocity of slow phase of upbeat nystagmus can be accelerating, decelerating, or constant. Upbeat nystagmus occurs with lesions in the lower pons and medulla and the anterior cerebellar vermis. Lesions here predominantly affect the anterior semicircular canal pathway, thus resulting in the upbeat nystagmus. Nicotine may cause an upbeat nystagmus in the dark, and we may find an upbeat nystagmus in upgaze in association with a horizontal gaze-evoked nystagmus, but that is non-localizing. And as we have discussed, a purely torsional nystagmus indicates a central origin, and it is usually associated with medullary lesions, and it may be part of an ocular tilt reaction. So this picture shows a torsional jerk nystagmus with the fast phase directed towards the right side. Periodic alternating nystagmus, although classified as a central vestibular nystagmus, is a horizontal jerk nystagmus, and the nystagmus has a crescendo-decrescendo pattern with an alternating direction in primary position. So the pattern starts from a null period followed by a right beating nystagmus of gradually increasing frequency and amplitude till it reaches a limit. Then the amplitude and the frequency of the right beating nystagmus gradually decreases till the eye goes back to the null period for around 10 to 20 seconds. Then a left beating phase starts with a gradually increasing amplitude and frequency till it reaches a certain limit, followed by a decrease in that amplitude and frequency of the left beating nystagmus till the eyes go back to a null period, followed by repetition of the right beating phase. Since periodic alternating nystagmus follows Alexander's rule, the patient may take up periodic alternating head turn to minimize the nystagmus and the consequent visual decline. During the right beating phase, the patient assumes a right head turn, and during the left beating phase, the patient assumes a left head turn, so that the amplitude decreases following the Alexander's rule. Periodic alternating nystagmus can be congenital or acquired. An acquired PAN is associated with cerebellar lesions and Chiari malformations. Acquired PAN has a characteristic oscillation cycle of 2 to 4 minutes. And unlike other forms of nystagmus, periodic alternating nystagmus has a very specific and effective treatment in baclofen. If a patient has a purely horizontal nystagmus in primary position, he should be observed for at least 2 minutes so that we do not miss a periodic alternating nystagmus. Congenital nystagmus manifests latent nystagmus, and nystagmus associated with severe bilateral visual loss may also be alternating, but they are not as periodic as periodic alternating nystagmus. Thank you for listening.